All right, everybody, in the interest of those of you who are all here, welcome to our clip session. And it's great to have you all here. And tonight we are privileged to have Dr. John Cooper, who's one of our amazing hip and knee surgeons. John went to Duke undergrad, so he's one of those Dukies. He then came to Columbia Medical School, where I first met him a few years ago. He did his residency training at Lenox Hill and then a fellowship in adult recon at Rush. He initially went back to Lenox Hill for his practice. And then when I became chair, one of the best things I ever did was I stole him, brought him back to Columbia. And as I've told this group, the CLIP students, one of the best things I've been able to do as chair is just bring incredibly talented faculty to Columbia. And John is an incredible educator. He won Teacher of the Year award the first second he arrived back. He has really revolutionized anterior approach to hip surgery. I was in his OR the other day and his incision is now about this big. I have no idea how he can put a hip in through that incision. I've sent family and friends and VIPs and not VIPs to him. He's just an incredible doctor and physician, surgeon, educator, father, husband. And so we've been really blessed to have John join us. So John's going to talk to you guys tonight about anterior total hip. And then as always, we'll have plenty of time for a little bit of Q&A for Dr. Cooper and then time for you guys for your small groups. Thanks very much.
Awesome. Thanks, Bill. It's really great to be here. I appreciate the introduction and the opportunity to meet everyone. I can't believe what a crowd there is tonight on Sunday at 9 o'clock. It's amazing. So let me see if I can get the talk going. Can you guys see the screen?
Yep.
Great. So I'm going to spend the next half hour, 40 minutes talking about my passion, which is total hip arthroplasty, and it's a real pleasure to be here. So disclosures, none of which are relevant to tonight's talk. A lot of these companies make parts that are associated with hip replacement, but I'm not going to mention anything specific. And I was going to start with an overview of total hip arthroplasty. And this is an operation that, along with a couple other things, total knee replacement, shoulder knee arthroscopy, basic fracture care, which is really one of the bread and butter operations of orthopedic surgery. And no matter where you go to train, no matter what program you're in, you're going to see a lot of total joint arthroplasty, and you're going to get your hands dirty with this. And so it's important to understand it. And the more you understand it, the more you can help people. With all due deference to the other faculty on the screen, this is also the best operation in orthopedic surgery. It's been dubbed the operation of the century. This was a Lancet article in 2007 describing just how far this operation has come since its beginning in the 1960s. It's one of the most reliable things that we do as orthopedic surgeons at getting patients back, up and moving, and out of pain. It's really incredible how much the technology has changed. It's incredible how much the techniques have changed. And that has allowed us to do an operation that was always good and make it just extremely reliable at getting patients, better, which is why we're all in this field. And this is something that, thankfully for me and all of you, is growing. Every few years, there's another article that comes out with updated projections on where this is headed. And this is one that came out last year in the Journal of Rheumatology. You can see we're doing about 500,000 total hip replacements in the United States now, each year. And over the next 20 years, this is projected to almost triple. So there's going to be a huge demand for this, much like with total knee arthroplasty. So lots of room for many of you to go into this field. Bill asked me to talk and focus a lot of tonight's talk on kind of a newer approach to this, which is the direct anterior approach. And it's a special topic of interest to us at Columbia because We have evolved pretty quickly in the last few years to have this be our predominant way of doing hip replacements. And I'll talk a little bit more about that in just a few moments. But I wanted to backtrack and first, ask what is an anterior approach? I mean, we hear anterior approach, we hear posterior approach, and I'm sure many of you already know this, but I'm sure some of you don't. And when we talk about anterior approach or posterior approach, we're talking about that in reference to the abductor mechanism, which is the big, powerful muscle group on the side of the hip that's responsible for hip stability, for gait. When we approach the hip in front of that, that's called an anterior approach, and there are several variants of that. When we approach the hip behind the abductor mechanism, it's called a posterior approach. And again, there are several variants of that approach. And there are also approaches that we don't do so much anymore called a direct lateral approach, where we go right through the abductor mechanism. So with that in mind, this is the most common approach that's done in the United States today. This is the posterior approach to the hip. The patient's typically in a supine position, in a lateral decubitus position with the operative side up. You can see the greater trochanter is exposed by splitting the gluteus maximus muscle in half. And as that muscle is split in half, the big gluteus maximus muscle is split in half, it exposes the posterior aspect of those abductors, as well as the short external rotator muscles on the back of the hip. And in order to get into the hip from a posterior approach, you need to divide the piriformis, the superior and inferior gemelli, the obturator internus, the obturator externus, and the quadratus femoris. So it's a fairly big muscular dissection off the back of the hip joint to get into the hip from a posterior approach. But this is, again, the most common because it allows really reproducible, really fantastic exposure to the hip. It's one that's fairly easy to do. And it's one that is taught throughout our country. And is one that I'd say most people utilize as their go-to operation. The direct lateral approach isn't done so much anymore. I bet many people on tonight's Zoom probably won't see this in part of your training because it's fallen a bit out of favor as we've gotten better at other approaches. This is an approach that's certainly still done, but it's in the 5% range across the country, and many programs don't offer this anymore. It approaches the hip through an anterior capsulotomy, but in order to get there, you divide the abductor mechanism and peel the anterior third of it off the trochanter to allow access to the anterior hip. When you do this, at the end, you need to repair it back. And when you repair it back, it typically works. But the biggest problem with this approach was that sometimes it didn't, and patients were left with a persistent limp or persistent lateral hip pain. And that's one of the main reasons this has fallen a bit out of favor in modern training programs because of that persistent limp that you would see in some patients. The anterior-based approaches are the ones that are gaining in popularity. And these are certainly replacing the direct lateral approaches, which were done because they offered fantastic stability to the hip joint. The anterior-based approaches also offer that, but in a way that spares the abductor mechanism. And the one that we're going to focus on mostly tonight is the direct anterior approach, which utilizes the internervous interval between the sartorius and the tensor fasciolata in the front of the hip superficially, and then between the tensor fasciolata and the rectus femoris muscle deep to allow access to the anterior hip. The other popular anterior approach is the mini Watson-Jones approach, also called the mini anterolateral approach. And I highlight this because of the 6 full-time arthroplasty faculty at Columbia, all 6 of us are using one of these 2 approaches as our main preferred anterior hip approach. 4 of us are doing the direct anterior approach, and 2 of us are doing the anterolateral approach. So if you're training at Columbia, you're going to see a heck of a lot of anterior hip surgery. And I think this is good because we'll get into some of the benefits of this and why this is gaining so much in popularity. A bit of history, I mentioned this is new. It's not really new. It's just new in how widely it's utilized. It's a technique that's been around a long time. It was popularized in the 1980s by Kegi based in Connecticut, but had been around a lot longer than that. You described way back in the 1800s, and utilized for some procedures in the early and mid 1900s. So why is this the technique that we have come to utilize at Columbia? Why is this my preferred technique? If you had been at Columbia 4 or 5 years ago, you would have seen the vast majority of the hips go into a posterior approach. And now it's uncommon to see that at Columbia. So why has this become our preferred technique? So across the country, more than 40% of US hip surgeons use it as their primary approach. It's the only approach that has its own textbook with it. And the second edition to this textbook is coming out in a year. And 4 of our faculty have contributed chapters to this textbook. The potential benefits, and one of the reasons this has become so popular, is that it's a less invasive technique with less soft tissue damage, associated with less postoperative pain, which can lead to a faster recovery without postoperative restrictions. The supine nature of it allows pretty easy use of intraoperative live fluoroscopy, which can allow improved component positioning. And these combined can lead to a lower rate of instability after surgery. This is a really good study, and one I think that everybody should be familiar with, if you're going to do orthopedic surgery. This is specific to the hip, but the same principles apply across. This is a study out of, I think out of Sweden, that looks at persisting muscle atrophy after major open surgery. And in this surgery, they followed patients prospectively after posterior approach hip replacement, preoperatively, 6 months postoperatively, and 2 years postoperatively. And they were able to tabulate the cross-sectional muscle volumes and summate those across 3-dimensional modeling to look at the changes in muscle density and muscle atrophy after surgery. And what they found was that after you did surgery, the muscles that you cut atrophied. But even at 2 years, those muscles stayed atrophied. So the damage that we do in surgery, patients heal somewhat from, but there is persistent muscle atrophy that's with these patients for a long time. And that's one reason why, as we're doing surgery, we don't want to do necessarily more soft tissue dissection than is necessary to do the operation well and safely. We repeated a similar study in our hands a few years ago, and this was a multi-center study where we looked at cross-sectional muscle volumes using MARS MRI, using a metal artifact reduction sequencing MARS MRI technique, where we could really get a good sense of muscle volume and changes. And we recruited both anterior approach and posterior approach patients. And we found that in the anterior approach group, patients had a little bit of muscle atrophy from their preoperative state at 6 weeks, but by 6 months, it had mostly all recovered, with the exception of one muscle group, which is the obturator internus. When we compared that to the posterior group of patients, we found that similarly, most patients atrophied at 6 weeks, but in the posterior approach group, where there was more muscle dissection, these patients had persisting muscle atrophy at 6 months, which had not recovered. And in some of these muscle groups, had gotten even worse over time. And you can see this is in the muscles that you tend to divide and cut on the way into the posterior hip joint, the obturator internus, externus, piriformis, and the quadratus femoris. This is also a widely cited study. This looks at muscle biomarkers and markers of inflammation after surgery. And this compared patients getting a direct anterior approach surgery to those getting a minimally invasive posterior approach hip arthroplasty. And they found that in these patients undergoing the anterior approach, they had significantly lower biomarkers released of muscle inflammation. Specifically, the creatine kinase marker was 5.5 times lower in the postoperative recovery room in the anterior approach group, and over 2 times lower overall than the posterior approach group of patients. So doing less muscle dissection on the way in, does this lead to a faster recovery? And although there are some controversies in the literature with some studies showing no difference, a substantial number of the studies favor the anterior approach, leading to a faster recovery. This is a systematic review and meta-analysis of 9 of those studies through June of 2018 that identified almost 800 hips from an anterior posterior approach. And they found that when they looked across these studies, the anterior approach patients had better hip scores at 2 weeks and 6 weeks, but these differences went away by 12 weeks and were not there at a year either. They found that patients undergoing an anterior approach had less pain at 1, 2, and 3 days after surgery, and there was overall no difference in operative time or post-operative complications. Now, there have been a number of randomized controlled trials that have come out since that time. I think this is probably the best one. Most show fairly similar findings, but this had, I think, the best methodology. And this is from the Mayo Clinic, published a couple of years ago, where they randomized about 100 patients to an anterior or posterior approach. And their findings were patients undergoing an anterior approach had a significantly faster time to be able to walk without a walker, to walk without any aid, to stop all narcotics, to go up and down stairs with a gait aid, and to walk 6 blocks. These differences in recovery averaged about a week faster from the anterior approach compared to the posterior approach. And again, they had no differences at a year. So these are early functional differences that patients see, early differences in pain that patients see. But what I counsel patients when they come into the office is that these differences, they're not there forever. They tend to go away, usually by 6 to 12 weeks, and they're certainly not long-term differences. And this is one of my patients. He sent me this video, and he actually didn't only give me permission, he actually encouraged me to use this in a talk. But this is him about 2 weeks after his ambulatory right hip replacement at a gym. And gosh, don't we all miss those times where we could go to a gym and do this kind of stuff. But this is him less than 2 weeks out from surgery, feeling really well. In addition to the early functional benefits, which I think are attractive to patients, the real reason that I prefer the anterior approach relates to the supine nature of it and some of the benefits it allows me to do in terms of component positioning, consistency of surgery, and one of the big ones is on acetabular positioning. So when we talk about acetabular positioning, there are a couple of things that we talk about in terms of measurements. The two angles that we commonly talk about are the abduction angle, or basically how flat or how vertical that cup is. We want this in the 40 to 45 degree range. The other angle that we talk about is the anteversion, which is how much that cup is pointed toward the front of the pelvis versus to the side. So the native hip anteversion is about 15 degrees, but there's a fair bit of variability. And you can approximate the anteversion based on the size of the ellipse that you see, or how open the cup face is. And when we look at these two angles, a number of decades ago, somebody described a safe zone, which is a combined anteversion and abduction angle that's thought to be safe or protective against dislocation. And this is a bit controversial now, and I'm not going to get into kind of the subtlety of why this is less sure now than it was then. But overall, we want to try to put the cups in a relatively consistent range to minimize our risk of component impingement, soft tissue impingement, and dislocation. And that safe zone is thought to be somewhere between 5 and 25 degrees of anteversion, and somewhere between 25 and 45 degrees of abduction. And this is that patient's cup here, well within the safe zone. And you would think this is a fairly broad range and something that's fairly easy for us to hit as surgeons, but it's not. This is also a widely cited study from the Harvard group, looking at all the surgeons over about a 5-year period who put their cups in through a posterior approach, anterolateral approach, or minimally invasive approaches. And you can see they were hitting the safe zone only about 50% of the time with their component positioning. So something that's really hard to do consistently without guidance. Now, when we do anterior approach, the majority of surgeons who utilize it in the supine position utilize a live intraoperative fluoroscopy. And what that allows us to do is, as we're putting the cup in, it allows us to change the angle of the cup to be fairly consistent and before we really impact it. And you can see on the images on the left, the subtle differences in anteversion between the first image and the second image before we fully seat that cup down. And a couple of years ago, I think it was in my first year of practice at Columbia after coming over, one of the Columbia residents came up to me, James Len, and he said, "So Dr. Cooper, what happens if the C-arm's off a little bit? How does that affect your ability of judging the cup?" And this is certainly something that we know. If the C-arm's not positioned perfectly, we can't trust that data on what the anteversion looks like. And so one of our jobs as surgeons is to make sure we position that C-arm consistently before we start relying on that data to interpret our cup abduction and a cup anteversion. And that was my explanation to James, and I thought that was sufficient. And he went and he met with Eugene, who was our chief resident last year, Eugene Zhang. And about 2 weeks later, they came back with this paper that they wrote that described how subtle changes in the C-arm position would affect what we perceived as the cup anteversion and abduction. And something as little as a 10-degree change in the C-arm tilt, which is an easy mistake to make, would cause our perception of the anteversion to be off by about 7 degrees, which really highlights how critical it is to make sure that we're using this technology appropriately. But when we do, we can be very, very consistent with it. And these are numbers from my mentor, Jose Rodriguez, early in his learning curve of the anterior approach, where he was hitting these numbers not 50% of the time, but 97 to 98% of the time for your inclination and anteversion. So having that technology, understanding how to use it, and applying that intraoperatively can really improve our ability to be a good surgeon. Supine nature of and intraoperative fluoroscopy also has benefits on the femoral side. It allows us to avoid undersizing the stem, get the right size stem in, which prevents subsidence of that femoral component. And one of the things that's really important to patients is making sure at the end of surgery, their legs are the right length, that we didn't leave one leg too short or too long. And that's a struggle from a lateral position. There are lots of techniques that are described on how to match that as consistently as you can, but even with those techniques, you're not always perfect. In an anterior supine position, we not only have the templating that we rely on, we have that live intraoperative fluoroscopy, and we also have the ability to come down to the foot of the table and feel those leg lengths ourselves as the surgical team to make sure we've achieved that consistent leg length equality that we want to achieve. So when we do that, when we use intraoperative fluoroscopy to position our components appropriately, when we restore length and offset, and when we minimize our soft tissue dissection on the way in, that has an effect on the stability of the hip joint. And the reason that this is important is that instability is our biggest Achilles heel in hip arthroplasty. If you look at the literature, the modern total hip arthroplasty literature, it suggests our rate of instability as hip surgeons is somewhere between 1% and 3% over a patient's lifetime. And it's our #1 cause of failure of modern total hip arthroplasty is dislocation. The anterior approach, again, a little controversial because the literature is not completely consistent on this, but there are a number of studies that show a lower risk of instability from an anterior approach. This is a Kaiser registry study of about 40,000 patients that cuts that rate of instability down by about 50% to 0.8%. This is a Dutch arthroplasty register of about 150,000 total hips. And you can see how the instability risk from the posterior approach grows over the patient's lifetime compared to the direct lateral or the anterolateral or the anterior approaches, which is about half of that over the patient's lifetime. That's because you don't violate the posterior capsule and those posterior stabilizing structures. So in our hands, we just looked back at this last week, actually, because we submitted an abstract and a video to the Academy looking at the risk of instability in our hands, utilizing intraoperative fluoroscopy. And in a 2-surgeon series, our rate of dislocation was 0.12% over about 2,500 cases, with none in the last 2,300 cases that we've done. So applying this right can really make a big dent in our biggest risk of complication after surgery. The last bit I wanted to cover were some intraoperative videos and pictures and techniques about what you'll see in an anterior approach hip. And I know many of you guys have probably already seen this. There are 2 major ways that we use to do anterior approach hip surgery. Probably the slightly more common way across the country is with a traction table. The HANA table that you see here is the most popular of those. And one of our Columbia faculty member, Dr. Taka, uses this routinely. The other way, which the other 5 of us use, is a standard operating room table that you'll find in any operating room. This has a few advantages. You don't need to buy the special table. You don't need an assistant to manipulate the leg. It's a fairly simple workflow that's controlled by the surgical team. It allows that direct assessment of leg lengths at the end of the case. We can do easy dynamic stability testing on the leg. And it can also decrease the risk of fracture because you don't have a big table contraption swinging the leg around without a feel of the soft tissue tension and stress across the femur. Not a big difference in these techniques. This is a recent systematic review that shows really no difference other than some minor differences in blood loss and operative time in favor of the standard table. But this is our setup in our operating rooms. As you can see, standard operating room table. We position the patient supine on here. We want to make sure that the bottom half of the bed is free so that we can bring in fluoroscopy pretty easily. We position the patient such that their hip is at the break of the table, and this allows hip hyperextension during the case. We prep both legs in, even though we're only operating on this patient on one side, because that's going to allow us that direct assessment of leg lengths. And once we put the drapes on, this is what things typically look like. We've got access to that operative left hip. We've got the anterior superior iliac spine in the field, and we're prepped down to about the mid femur. The operation, anterior approach exposure, which I'm not going to get into detail here, but it's a pretty simple exposure through that intermuscular and internervous plane. We get down to the hip capsule, do an anterior capsulotomy, which allows us to make the neck cut. We do that with an oscillating saw. Once the neck cut is made, we're able to remove the femoral head. This is an in situ neck cut, so we dislocate the femoral head like that. And with the femoral head out of the way, we're able to ream the acetabulum. And again, you can see direct access to the acetabulum. You've got a pretty good view with the lighted helmets to see directly into that acetabulum. Once the acetabulum is prepared, we're able to impact our cup. And you can see this is me guiding one of our fellows last year in the proper orientation under fluoroscopic guidance before we start to impact that, so we can get that consistent cup positioning every time. You can see the fluoroscopy machine is right there on top of the hip, allowing us to look at the C-arm. Once the cup is in, we focus on the femur. And as you see on the opposite side of the table, there's Dr. Jamie Confino. Happy birthday, Jamie. I think it's your birthday today. But this is us positioning the non-operative leg up on a Mayo stand. And that's going to allow us to adjust the operating room table to hyperextend the ipsilateral operative femur. We need to wait on anesthesia to do this. So you can see hyperextension of a leg, and then we're going to tilt the table back into Trendelenburg, which is going to put the hip kind of up at the apex of the table. With that positioning, we're able to put the operative leg in a figure of 4 position, kind of tucked underneath the non-operative leg, which allows us, with the right exposure, easy access to the proximal femur. And this is important that I said with the right exposure, because this is, I'll get into this in a moment, but this is where I think issues happen with the anterior approach. But with the right exposure, with the right releases, you can get this consistent exposure every time. Once the broach is in, we do a trial reduction. We are able to go down and field leg links directly. We're able to do dynamic stability testing anteriorly, directly, or posteriorly if you want to. And we bring the C-arm in, which allows us that intraoperative shot to check our offset, to check our leg length, to check our femoral sizing, all that before we open the components and we close the patient up. So we put the stem in, get our final fluoroscopic shot, and we do this at the end of every case so that you're never surprised at the end of a case what things are going to look like. I remember training, the first 3 years of my training, I only did posterior approach in residency. And we were all waiting around and waiting around and waiting around after every single case to see what the x-ray looked like. Because we wanted to make sure that we got the offset right, the leg length just right, the cut positioning just right. And there was always that little bit of angst before you got that x-ray. But here, none of that is present because you're always looking at what you're doing before you close. So pearls and pitfalls, really only one that I wanted to talk about. There's a ton of stuff we could talk about, but the major one I wanted to talk about is the femoral complication risk. And this is real, and this is one of the biggest drawbacks to the anterior approach is that when it's not done well, the risk of femoral complications is clearly higher. Those can be intraoperative femoral complications like perforation, fracture of the greater trochanter or of the calcar, or they can be postoperative complications like failure of osseointegration, stem subsidence, and periprosthetic fracture like you see here. And there's paper after paper after paper that report increased risk of these complications compared to a posterior approach where you've got a very easy, straightforward exposure to the proximal femur. Most of this is attributed to the learning curve. And that learning curve varies, obviously, depending on who's doing the operation, because we all learn at different paces, and we all use different resources to help us learn, but somewhere between 20 and 100 cases. And doing your learning curve in residency makes such a huge difference in your ability to apply these things when you get out into practice, compared to how many people have learned the anterior approach, which is well established into practice, and then switching from an approach that you're good at, which is a much more difficult learning curve than learning over the course of 5 years. So the anterior approach undoubtedly is a more difficult femoral exposure. This is the biggest drawback to it. The femur is not easily accessible and can get caught behind the acetabulum if not exposed well. And you can see that here. This is kind of the position the femur starts in before you do your releases. And if you try to approach the femur and put a broach or a reamer into that femur before it's really exposed and elevated, you run the risk of perforating or over-anteriorating the broach and perforating posteriorly, or perforating laterally through varus broaching. And this takes us back to anatomy. This is all anatomy. It's all understanding the hip capsule. It's all understanding the pericapsular structures and where they insert, and which are deforming forces in which positions and which you need to release to unlock the femur and get it where you need it to go. We did a cadaveric dissection in my residency that we were able to get these pictures from, that shows the relation from the capsule to the rotators. And this is one of those cadaveric specimens that shows the anatomy here, the gluteus minimus tendon anteriorly, the piriformis superiorly, the obturator internus, which snakes underneath the piriformis and goes a little bit more anteriorly, and the obturator externus, which is more inferior and more posterior. And so if you think about this femur trying to go anteriorly and elevate out of the incision, this obturator internus is going to be the biggest deforming force, especially as you externally rotate that femur and try to bring it out. This is going to need to be released in order to do that. This is less of a deforming force posteriorly in the obturator externus. So when you do those releases, you're able to free the femur from behind the acetabulum. You're able to elevate it up. And in that position, you're able to get direct access to the femur, both in the coronal and sagittal planes. And lots of tips and techniques and tricks on how to do this, and lots of education. And this is a big part of doing these cases with faculty, is understanding how and where and when to do these releases to get that consistent elevation. So with that, I will wrap things up and conclude. So the anterior approach is a widely used approach. If you look at where it was back when I learned it in 2009, this is the first year that ACUS did a poll, and you can see about 15% of surgeons were using it across the country in 2009. And every year that they've taken a poll, it's increased in popularity and prevalence. Last time the ACUS membership was polled, it was about 40% of us were using it as our primary preferred approach. And we're going to do another poll next month at our hybrid virtual in-person meeting. And I would be surprised if this wasn't above 50% now. The early functional results are superior. This is something that's been shown consistently again and again. And one of the reasons that I think this is an appealing approach to surgeons and patients. The supine positioning is invaluable at allowing intraoperative fluoroscopy, which can aid implant positioning and a direct assessment of leg lengths. And there are some real drawbacks to the approach, but with the right understanding of anatomy, the right training, the right education, these risks are clearly avoidable. These are things that we don't much think about anymore, you know, in our hands, thankfully. But they're related to the femoral exposure and preparation. And that's one of the reasons I think it's important to learn these things, you know, in your training. So with that, I'll stop. Guys, thanks very much for your attention. Again, a real pleasure to be here tonight and to be able to share with you.
Thanks, John. Can you stop sharing? Perfect.
Sure.
So it's 9:38, perfect. We have a few minutes for you guys to be able to pick Dr. Cooper's brain. But before you do that, as you guys are thinking about it, I do have one question for you, John. And, you know, we talk about what we do in our various subspecialties sometimes, and we do get into this technology over reason debate often. And so something becomes popular, it becomes a fad, it becomes a tipping point phenomenon, and then all of a sudden everybody's doing it. And then several years later, it kind of swings back because what was very popular becomes less popular. And my question is, as a young surgeon, how do you fight against the one that's gonna come back to bite you versus the one that you think actually does have a significant change in patient outcomes and in how you are going to approach the problem? So I guess the question that we face as orthopedists is, how do you avoid the fad and do something that ultimately is actually going to be better than what you were doing previously?
It's a great question, and one that's much larger than surgical approach. You know, I think it depends a bit, Bill, on where you're starting. There are some things that we do that don't work so well, and you know, across any of the subspecialties that we do, and in the areas where we don't have a great solution, and there are 4 or 5 or 6 different solutions that we use to try to you know, address a problem. It's easier to adopt something new or try something new in a place where we don't have a great solution. In something like hip arthroplasty, where we're already so good at doing this so consistently, it's a much bigger, for me, something that I would worry a lot more about changing into new technology, trying something new, because, you know, it's not a problem that we haven't solved yet. We've more or less solved this problem. And that's why I think the anterior approach was around for so many years before it got popular, is because a posterior approach hip or a lateral approach hip was still a really good operation. And it took a long time for a couple of people plugging along with the anterior approach that would train, you know, one person would train 2 people a year, and they go out and 2 more people would start to do it the next year. But it's something that wasn't really widely available. And it took a long time to reach that tipping point. But in the anterior approach, I think as we got better education, better visitation programs, better equipment to allow us to do that, it allows us to scale this, the benefits from the anterior approach, and allow us to reach that point where it started to grow pretty consistently since mid-2000s through today. And that's something that I don't see us going back on, because the people who are learning the anterior approach now are mainly learning it through training programs. And those people are the ones who are going to be able to avoid that learning curve where you make your complications worse for a period of time before they get better.
Things like, here. Can you tell us about the safety in a hip fracture using anterior approach and with an osteoporotic proximal femur? Can you pull on it as hard or lever on it? Is it safe to do?
That's how I learned. You know, once I got out of training, my first 35 hip replacements, Charlie, were hip fractures, because opening up shop in Manhattan, nobody wanted to send me patients for hip replacements. So I got the patients who fell and broke their hips. It's a little bit of a different patient population. The bone is not as strong, but certainly you can do this through an anterior approach. Without the soft tissue contractures, your exposure is a little bit easier, but you're right, you want to avoid torquing on that bone for sure.
Who's got a question for Dr. Cooper?
Hi, Dr. Cooper.
Oh,
Thanks,
sorry.
Alex.
Hi, Dr. Cooper. My name is Alex. I'm a fourth-year medical student from CUNY School of Medicine here in New York City. That was an excellent talk. Thank you very much for sharing your knowledge with us. I'm curious, you mentioned a lot of femoral complications with your anterior approach hips. I'm curious what your your experience has been with using cemented versus uncemented femoral stems in preventing those complications, and also on the flip side, on the acetabular component, what your experience has been using unipolar and bipolar constructs for your acetabular components.
It's a good question, Alex. The cemented stems were at one point almost a lost art. I saw 3 cemented stems throughout my residency and training and fellowship training combined. It's something that I do about 25% of the time in my own practice because I think in osteoporotic bone, there's great literature to support the fact that it's better early functional results, a long track record, a durable 20-year track record before you start to worry about loosening. And it's something that we're certainly teaching now at Columbia, so that every resident that leaves should have seen a number of cemented hips and should have had the opportunity to put cement into a canal and see what it feels like. Especially this hip fracture population, which we'll all be taking care of on trauma call. It's a skill that we need to know. And we went from our native about 5% cemented hips across the country. Now we're up to about 15%. So we've dipped and we're coming back up again, thankfully. Unipolar, bipolar. So on the hemiarthroplasty side, not a big difference there. On the total hip arthroplasty side, we're using dual mobility bearings, which is kind of that bipolar inside of a shell for patients who are high risk for dislocation with improved dislocation rates.
Caroline, I think you had a question. Thanks,
Yes,
Alex.
I did. Thank you, Dr. Cooper, again for your talk. That was very interesting. So I am wondering on the uncemented side of the femoral component, if you have a preference between fully coated versus like the proximally coated, like an accolade or something, and kind of what your reasoning would be as far as choosing one of those.
It's a good question, Caroline, and that's certainly a whole nother talk to talk about stem selection. I don't think one stem for every patient is the right model. That's something that I think it's easy to fall into, where if you're going to do a hip replacement, you're going to choose your one stem that you always use, because our anatomy is not always the same. When we're doing a hip replacement, we want to match the patient's anatomy. We want to match their offset, their leg length. We want to match the flare of the calcar, and we want to maximize our chances of stable fixation. And usually you can do that with a non-cemented stem. Occasionally a cemented stem is better to do that. And as you bring up, there are a number of different non-cemented or uncemented designs, like the proximally coated stems, the fully HA coated stems, the collared stems, the cylindrical stems. My preference is the fully HA coated stems because they offer a little bit larger margin of safety error. So you can get fixation anywhere along the length of that stem. Collars have made a big difference in our initial stem stability, which you need for initial osteointegration of these stems. But a nice question on a complicated topic.
Thank you very much.
All right, we have time for one more question if any of the students have.
I actually have a question, Dr. Cooper. Thanks for taking the time to talk with us tonight. My name is Jared. I'm one of the fourth years from Mount Sinai. I was wondering if you could talk a little bit about your decision process when you're trying to figure out if you're going to do an anterior approach or a posterior approach, and whether or not you take into account specific patient factors and just how you sort through that in your own practice.
It's a good question, Jared. There are certainly patients that you could look at and you could look at their bony anatomy and look at their body habitus and say this case is going to be more difficult from an anterior approach or less difficult from an anterior approach. And if you're in your learning curve, I think you want to separate the ones that are more difficult and do those through the approach that you're more comfortable with. Personally, I do 100% of mine through an anterior approach because that's what I'm most comfortable with, even for the more difficult anatomy patients. It's been a while since I've done a primary posterior approach hip replacement, like 9 years, a while. So I would do everything from an anterior approach because that's what I think I'm most consistent and best with. But if you're somebody who does both, then the wider iliac flares that come up almost like Mickey Mouse ears, that are going to block your femoral exposure, are the ones that are more difficult to do. The short varus necks are the ones that are more difficult to do. The more contracted or more muscular patients are the ones that are more difficult to do. And if you're more comfortable with a posterior or lateral approach, you should probably do those through the approach you're more comfortable with.
All right, Robbie Turk gets the last question because I guess he has his hand raised. Thanks, John Brown.
No pressure or anything. Thanks, Dr. Cooper. So my question is just about patient positioning. And I did have to take off for about 5 minutes. So I'm sorry if you did address this, but I saw in the picture you had the patient on a radiolucent table versus I've seen a couple times hand and table being used instead. And I was wondering if that makes any difference when you're, for the anterior approach.
So there are two different schools of thought that for the tables that we use, there's the standard table that most of us at Columbia use. There's the traction table, like the Hanna table, that a large contingent of anterior approach surgeons use, Rob. Both work well. They're a little different, but both work well. If you're on a standard table, it's helpful to have 2 assistants. If you're on the Hanna table, the table acts almost as one assistant. So you could do the operation more easily with just 1 assistant, although you can certainly do a standard table with 1 assistant as well. Not a big difference though. It's more of how you train. And once you are used to it one way, you don't tend to go back and forth amongst the different tables because they are different.
All right, I think we'll call that so that we have time for the small groups. John, thanks so much. It was awesome. And for all our CLIP students, I'm going to send an email out to you guys. I have a thought about maybe doing something with you just before the applications go in and just giving you guys some time to ask some questions. So I'll send you an email about that. But thanks, John, and good night, everybody. Have fun in your small groups.